Hello, colleagues, and I'm grateful that we are here together. May I welcome everyone who have joined this session. We are hoping others are still coming and they will find us on the way. Today we wish to take at least 50 minutes because now we are almost 10 minutes away from our session. So I'm welcoming everyone and I'm welcoming our team. I can see today we have our long friend Zamo, and I can see others have come and exited. I think the issue of the network. Some I saw, but now I cannot see them. But for the sake of time, may I say that we may start the session for today. So maybe for recap, let me just recap that in the previous sessions, we were looking at dyspnea, the management in palliative care. So we're looking at what is it and how frequently it happens and what can we do to manage it. It was presented by Mr. Lukele. And then we also had the privilege in our previous session to have a so painful case presented by our social worker. So I'm sorry, there's a colleague who wants to join, so I don't know the network has done. So may I just take a minute and address this patient, this client or this colleague of us? I don't know, some colleagues are complaining that they are unable to join. So yeah, we are still trying to support them to join. So I was just saying we had a very interesting case from presented by our social worker in our last session. So it was so humbling to see what some of our clients going through. But we think that our RFM team were able to come in to assist, especially in the accessibility of morphine. So there were these challenges that sometimes the patient is unable to access it, of which is one of the things I think as a palliative care team here, joining together, we need to work on this issue. Just to share some of the experiences, I went to Nzingeni in the past weeks, and I had a good partnership with Peace Peak palliative care nurse, I will say so. I will not mention her name because she's not here. We had a good time. So to enable the accessibility of the morphine. So may I recommend and say we need to create a strong partnership and communication as clinicians to enable the flow of care. But we are hoping our social worker was able to communicate with RFM team to address that issue. But some of the issues that were there was that I'm happy today we have Zamo here. Maybe he will help us, but I don't know, maybe she will help us. We had that client who was has this the query cancer, but then couldn't be initiated on treatment until a Lancet laboratory was done. Unfortunately, they requested something around 7,000, of which the socio-economic status of the patient, as per social work report, the patient couldn't afford that. And then it became a stumbling block or a barrier for this patient to access the service. So it was so painful in that way. So yeah, I'm seeing those colleagues coming and going. I think it's the network problem for today, but we are hoping they will be back very soon. So at this point in time, may I introduce you to our today's business? We were supposed to have a case from RFM team, but I'm aware that they are having another event tomorrow, so possibility today they might not be in. So for that reason, it's very nice when the owners of the case present, because they are able even to give us details that are not there. But what we have done as a team, we have included this case in our iEco platform so that you can access it at any point in time and read about it. But today we are looking forward to I don't know whether this is Mr. Mhlando. So may our colleague who have just joined now rename him or herself. Thank you. Now I can see who is this one. It's Malaika. Thank you. So we are hoping today we'll be looking closer to anxiety disorders that usually happens in palliative care. In this module, we are almost looking around the common symptoms that are there in palliative care. We are not going to look all the symptoms, but we'll look those different symptoms. We have tried to look around physiological one. We still to cover depression. We still to cover fatigue. We still to cover okay, I've mentioned depression, fatigue. We still to look around pressure sores or pressure ulcers, prevention and management in palliative care. And then we will close with the malignant wound management. So we are just looking there and there. So for these 2 or 3, so we're left with 5 sessions now to complete this module. After we finish this module, I will always encourage us to come back again. We'll have another module. I think this one will be fascinating and interesting, because we'll be looking at other topics like sexuality in palliative care illnesses. We'll be looking at spirituality and spiritual assessment and spiritual care. We'll be looking at family support. We'll be looking at the biopsychosocial spiritual model. So we'll be looking at this fascinating. So we are looking at different aspects of palliative care. So for today, so can we go straight to our presentation for the day? So today we will be looking at anxiety. So we'll be just sharing a bit on anxiety, and then I will request that we continue to share whenever we have to share something, we share it. I hope everyone can see my screen. I don't know if you can see my screen that side. You can share, or you can unmute and say you can see it. Can you all see the screen?
Yes, I can.
Okay, thank you, Zamo, for that feedback. So that one. So today I just want to say, let's look around this. We have 2 psychological topics that are most common in palliative care that we'll look at. We have depression and then we have anxiety. So one of the things that we normally say is that whenever we are creating our palliative care tools, let's have somewhere we will do frequent screening and assessment of anxiety and depression. So, because they are the most common psychological problems that usually our patients go through, we cannot ignore psychosis and others, but this is one of them that happens in the inclusion of substance use disorders that we discuss when we're talking about pain management. So today we have decided to separate anxiety from depression, so we can look at it a little bit closer alone. So when we look at this, we are going to help us to differentiate the types of anxieties, just list them so we can appreciate them. And also we have to understand the signs and symptoms of anxiety disorders in palliative care. And then sometimes we'll get the skills that we can embark on, or techniques or practices we can use to manage anxiety in palliative care. So we'll look at the introduction, risk factors, we'll look at the signs and symptoms, we'll look at the types, just listing them, then the diagnosis of certain common anxieties, looking at the DSM-5, and then we look at the stepwise management and conclusion. So I will just mention that this is not far away. In palliative care, currently there is I've been introduced to what we call in palliative care psychiatry. So these topics are tackled in depth in that module, which is called palliative care psychiatry. But today we'll just look at these ones. So in general and in definition that we have been even exposed to while we're even at school, is that anxiety is the state of tension, fear, worry, and apprehension. And it's normally a natural response to a perceived threat, okay? Whether it's a physical, emotional, spiritual, social, physical threat. So someone will respond, and then one of the responses will be anxiety. So the threat can be due to real or imagined life events, maybe a real issue of just death, maybe I'm by the road, then my car lose control, or I'm just missed by a truck, or thugs are knocking by my door, or I'm being told I'm diagnosed with the cancer stage 4, or imagining about the future, then I would begin to have certain anxieties. So anxiety is associated with hyperactivity of the autonomic nervous system that triggers flight or response. You know, sometimes you find yourself wet, you find yourself, there's a lot that happens when some people, they will fight you, some will run away. When a snake approach my room, what I will do, I will run away. So the anxieties, those are the responses. So normal anxiety, it's a normal reaction. For example, when you're expecting to meet a certain guest, or during the times of appraisals, when your manager or your supervisors to appraise you, sometimes you have those anxieties. Anticipating a newborn for women, because there's a lot of that you are expecting. It's a normal process, but I don't know what is going to happen. Expecting to do certain examinations or writing certain papers, or going for job interviews. We have experienced these examples. So moderate levels of anxiety improve performance. When you have a certain level of anxiety, it helps you to brace yourself and do better. And then high levels of anxiety will be appropriate if it consistent with the demands of the situations. So if it's appropriate for that, it is required. So that's normal. There is a certain level where we are saying that now we are expecting normal reaction or normal anxiety from our people or patients. But then we need to understand that, okay. Apologies, let me go a little bit back. All right, let me do like this. I hope now it's very nice. I hope now it's very nice. Okay, I was here. I want us to see, so I've talked about this one. So I want us to also look at, okay, I've talked about the normal anxiety sometimes that we have to experience. And then we have what we call anxiety that is pathological. So it is pathological when frequency and intensity of the anxiety responses are out of control. You know, when you can now not control the response that you have to that situation, or it's too much in proportion to what is triggering that anxiety. And we say that your anxiety has become pathological when it interferes with an individual's daily life. So then now we say that anxiety is pathological, or it requires an immediate attention from us as clinician to manage that patient. When a patient says, because of the fear that I have, I cannot do this, I cannot bath, I cannot work, I cannot go to church, I cannot go to where, then we can now begin to intervene, because that anxiety is now removing or reducing the patient functionality. So when you look at the factors that put patients at risk of these anxiety disorders, actually there's no specific that we can say this one is specific, but the risk factors are complex and they're different from each person and life experiences and the personalities. Let me make an example. If then, that's why it's very important to know a patient history before even breaking any bad news, you know. If that patient has a history of cancers in the family and have recent bereavements due to cancer, and then is diagnosed with cancer, you know, knowing that the patient has a history of such a problem, it helps you to understand how they handle bad news and stuff, because life experiences, some they get numb because of those experiences, some they become hypersensitive to such issues. Sometimes it comes with genetic vulnerabilities. A psychologist says that it skips generations. You find that if my grandfather had it, I will have it. If I have it, maybe my grandchildren can have it. And then sometimes stressful events like financial worries, you know, these ones, the triggers put someone at risk of having certain anxieties, especially when there are financial worries, and then the price of petrol is going to go up tomorrow, and the salary will come in 2 weeks' time. You know, then you begin to have anxieties because now you are going towards financial crisis. And sometimes with financial worries, some patients and some people engage on unhealthy financial decisions and management because of anxiety that they are going through. And sometimes performance worries and social work and school worries, you know, if you have certain worries, then you have this risk. But then today we want to focus much on chronic or life-threatening risk factors, whereby then the anxiety that is triggered, or that person has developed anxiety due to a chronic or a life-limiting illness, whether diagnosed with HIV, whether diagnosed with cancer, organ failures, you know, progressive conditions, sclerosis, you know, those conditions. So we are saying then that's one of the anxieties we are focusing on today. That is most of the risk factors that lead to our patients that we have. Then what does it mean? It means that this patient's anxiety is one of the prevalent symptoms our patients are going through. But then we might say they are not if we have not done data assessment or screening to see if they are going through. Most of the things you'll find them saying in Eswatini, you'll hear them saying that I fear death and leaving my loved ones alone, especially when the parents has young children or their spouses were surviving through them. Then they will begin to have anxieties of death, the fear of death. And then we are usually say that once they present with the one, is an opportunity for the team to discuss end of life and discuss death so the patient can prepare for that. Even we know that death is something we don't like, but in palliative care, we say, let's hope for the best and prepare for the worst. So another thing that is there, it's the fear of infecting their loved ones. Some patients, they will say that, I have diabetes mellitus and I have children. Maybe they are already obese and I'm scared I've already done this, transmitted this. Maybe they are HIV, maybe they have TB. They have different conditions that they think they will have play a major role for their loved ones to have those conditions. So they have anxieties. Some they even admit that because I have cancer, the person who goes to take care of me is at risk of developing cancer too. Some will even refuse to give care to their loved ones with cancer or have life-threatening conditions because they think by providing care, they will get it. So they have different anxieties, right? And fear of stigma, isolation by family and loved ones, when you're diagnosed with diabetes, stroke, cancer, especially sexual reproductive related cancers, which sometimes comes with libido problems. Some people will feel a stigma of half woman, half men. I have another client, I was discussing sexuality issues with her this week. And he verbalized to me that she is scared to engage on sexual relationships now because she has lost one of her breasts. So they have a lot of stigma, isolation, and that's anxieties. And sometimes they have fear of dependency on their family, losing daily function and losing their quality of life. So they have anxieties. Now I'm diagnosed with cancer stage 1. They now focus on their trajectory when they are low, no functional, totally dependent. So they are scared. Most of our patients, they are scared of disclosing the condition, breaking the bad news to their children, their family, and loved ones. So they have those anxieties. What if I tell them they leave me? What if I tell my boyfriend he decides to leave me, my husband decides to leave me and cheat for me and stuff? What if I tell my children they become hopeless? And the relatives would sometimes say, don't disclose the news to our loved ones, he will be hopeless. So they have those fears. And they have a fear of being in highly demanding treatment regimes. Once I'm told I have cancer, and then in my mind, I picture myself going for what I call chemotherapy, radiotherapy. Some even think of the opioid therapy because opioid therapy is not easy because it comes with the side effects, and then they're scared of constipation. They have a lot of myths about opioid therapy. So once we say cancer, people think of morphine. They think of the opioids. They think of the terrible situations that sometimes they go through. And sometimes, different conditions. If you say your patient has kidney failure, immediately they think of dialysis, they think of all these treatment that they go through. So then they go for, they react with anxiety. Okay, so those are examples. So these shows that this is one of the problems we need to discuss and share information about. So some of the signs of an anxiety include so anxiety differs per person. Each person has a different reaction to anxiety. And then some will have excessive uncontrolled fear, worry, accompanied by restlessness, tension, getting easily exhausted and fatigue, hyperventilation, chest pain, the breathing rhythms change. And they have difficulty in concentration, attentive, and remembering things. Like they developed a delirium dementia at one time. If I'm not delirium, and then they have sleep disturbances, insomnia, they call DMIS, disorders of initiating or maintaining sleep. Sometimes they're unable to sleep, sometimes they have difficulty to sleep until morning, at least 8 hours. Find that they wake up along the way. I was thinking about this. And there's this song of this, is it Biggie Zulu or who said that now Nemali I don't know these South African singers. So if nemali, you cannot sleep. If you have money, you don't sleep. But then the opposite is real, that also when you don't have money, you don't sleep. So you have a lot of anxieties and fears. And then follows the bad news of life-ending illnesses, yeah. Those are other things that accompany this uncontrolled excessive fear, difficulty in concentrating and mind going blank, irritability. They are very irritable. So you will find them changing moods. So there are also physical symptoms that you can find to these people. Sometimes they have tremors, shaking, increased shortness of breath, increasing blood pressure. Take their vital signs, you find them very high. And awareness of heart rate, they have palpitation, and then sometimes muscle tension, sometimes with dry mouth, nose, and vomiting. When you have anxiety, you just go straight to xerostomia one time. Sometimes some will have nose and vomiting, and then they will have some will have diarrhea and abnormal comfort. So we react differently. Some will have frequent urinary incontinence. Cool. So those are the languages people will say. So then you go to, if just you have missed by a car by the road, the first thing you're going to do is you are looking for a bathroom, so you can relieve yourself. So those are different reactions we face and see from our patients. So the anxiety or worry always comes with causes significant distress and interferes with social, occupational, and other important areas of functioning. And then we say that now these are problems. And sometimes the disturbance, it should not be due to direct physiological effect of substance use disorders. So to say that this is anxiety, it mustn't be withdrawal symptoms from a certain drug. So we need to differentiate between the causes. If it's drug that you have taken alcohol and then you are shaking, so we cannot say you are having anxiety, but that one is a withdrawal symptom of a certain drug you have to have taken. So there are many different anxiety disorders. The most common one is GAD, the general anxiety disorder, which is normally the general life. And it's according to the DSM-5, the symptoms must be there more than or at least 6 months. So yeah, another one is panic disorders, where it's a sudden unrest of fear, like it has just happened, like you've lost your breath just now. We say to us in Eswatini, utugile. So this is a panic disorder, and then at least if it has been there consistently, the symptom has been persisting for at least a month, then we are saying a panic disorder. And then we have specific phobias and phobias to certain issues that has lasted for at least 6 months. Social anxiety disorders, you cannot be public. You feel embarrassed to be in a public space. You cannot walk. You cannot go to church. You see those people because they are scared of that. Separation anxiety, which is sometimes most common in children, but it can also be diagnosed for adults. For children, it can be diagnosed for 4 weeks, lasted for 4 weeks. for adults when it's lasted for 6 months. This one is about, the person begins to have fear of losing their loved ones or being in separation of certain people. So this one is common because if families, when is the man has been diagnosed with stroke and then is bedridden, cannot go around the family and support the wife, then you'll see the man saying that the wife mustn't go outside the room because he is in separation. He's scared he might lose the wife. So, and then there are specific disorders I've said, maybe heights, niggles, they have different phobias. And then selective mutism, I've also put this one because, it's most common in children. And for a month, you find that these children just end up unable to talk when you are supposed to speak because of certain anxieties, and then unable to speak because he's scared. And then agoraphobia, which is environmental related phobias. And another one that I talk about is what we call adjustment disorder with anxious mood. This one is a stress response syndrome, and also have substance or medication-induced disorders. So there are many disorders, but the most common one, the panic and the GA, are most common the disorders, anxieties. Okay, so if the diagnosis of general anxiety disorder include that if the patient has excessive fear or worry occurring more days for at least 6 months and difficult to control the worry, and then we say plus these other symptoms that could include relentless feeling, uneasy, difficulty in causing irritability, including insomnia, and then that person is diagnosed as a general anxiety. And so the management of this one, according to the guidelines, is that you conduct the physical examination, you do your SME, mental status evaluation, you provide counseling, which is one of the key things. We do refer for psychotherapy if no improvement from that counseling, and then you rule out depression and substance use disorders, and you refill antidepressant, especially fluoxetine or sertraline, yeah. And then you also do anxiolytics for those who are unable to sleep. And the anxiolytic that is recommended here is lorazepam. It does good when it's time to help patients sleep. Okay, and sometimes we say refer to the team member, which is who is a clinical psychologist in our sake, very critical in palliative care. And in the country, we have them across the country, and we also have them in the National Psychiatric Hospital. So when we are conducting, one of the management of anxieties is its assessment. It's very important that whenever we are doing patient assessment, screening, whatever, at Hospice at Home, our documentation systems allows us to do spiritual screening, allows us to do use the PHQ-9 to do depression, and also help us to screen anxiety. So we do have the screening for that one. I will come with the tool in our next time, the name of the tool that was incorporated into our documentation and management system at Hospice. So the critical thing is to take psychiatry history and explore patient fears and stressors. Don't take lightly the things that the patients are saying. That's why it's very important to use non-judgmental language and be open to whatever you are saying, open-ended question for the patient. And you need to inquire, when you're doing the history, you need to inquire about the support system with the patient's life. Who is supporting you? How is the support? How is the perception of the patient's life now? And the support system that they have now across the trajectory of life. Last time I mentioned that when you are diagnosed, most of the time, especially the different conditions, they have different trajectories. We have a trajectory for cancer, as we have a trajectory for organ failures, where we have our hypertension, we have our organ failures there. And then we also have a frailty trajectory, which includes the stroke, we have our dementias, those frailties. So they follow different journeys. And then we have the palliative care phases and the functionality status. So you need to trace them so that you understand the supportive system that they have. And then you also inquire about alcohol and substance use behavior. I have one patient. Every time I visit this patient, he's requesting for at least one bottle of liquor because he has been drinking a lot before and now he has suffered stroke. So, yeah. So you understand them if they are taking it. We have patients who are cancer patients who are on opioids and who are continually taking smoking, tobacco, using tobacco, and some are taking alcohol. So we need to move them using cognitive behavioral therapy, especially we call it in palliative care positive motivational counseling. So we do motivational counseling. So we can help them to go for adaptive behaviors or coping mechanisms and move from the maladaptive behaviors. So we help them to do that so they can even quit using alcohol. Medical conditions, sometimes thyrotoxins, whereby then the body is releasing more of the thyroid hormone, which then lead to anxiety. And then we also conduct physical examination and MSE. You can get the mental health guide. It will help you to see how do we do MSE. And then do physical examination is very important to do that in any assessment that we do. So that is normal what we normally do for anxiety screening and management. Another intervention that we normally have that is good to do when you are taking care of a patient with anxiety after doing your assessment is to engage on psychoeducation. So this one is very crucial, and you emphasize to the patient and the caregiver to stick to the intervention plan and medication and therapy and counseling so that they don't default any plan we've embarked on. And to do that, we also bring in the principle of palliative care that says every time you are planning anything, let it be patient-centered, meaning whenever we are creating the goals of care, we need to center them around the patient. Let the patient be the major stakeholder who contributes effectively to the care and the decisions and the goals of care to be made. Remember, we are not doing things to the patient, but we are doing the things to support the patient on the life and on the quality of life they are perceiving at that state at that time. So it's very important when you're doing your psychoeducation, you encourage them, even the medication, how to take them and how to adhere to that, even the counseling and the therapies themselves, which most of the time is the psychotherapy that we are putting to them. If then we have embarked on stopping taking tobacco, then we are putting a mechanism or steps that we are going to follow. Then we encourage them on how best to follow that. Another thing we need to do, we encourage the patient and the caregiver to join an anxiety supportive group, if any available in a community, to find compassion and understanding and shared experiences. I understand in the country we have rehabilitative centers like the Hawane. There's one in Hawane whereby they take these people who have problems with drugs and they rehabilitate them. I've forgotten the name of this place, but you can help me if you know it. So if they can and then are able to join if a church is providing such therapies, we encourage them to join those groups of anxieties to support them cope with those anxieties and able to quit even non-adaptive or maladaptive behaviors. And then inform the patient and caregiver not to turn to alcohol, drugs to numb the feelings of anxieties. Because they will say that I prefer to sleep drunk because once I'm awake, I'm thinking of the death that is coming. I'm thinking about the pain that I'm going to experience. I'm thinking about the marriage that is going to crumble because now I'm like this. So they are thinking when they begin to take alcohol. or abuse certain drugs. So because of that anxiety, sometimes you may quickly judge them, but sitting down with other patients, understanding the way they are behaving and the why they are feeling that way, you end up understanding that some of the issues are cultural and some are spiritual. That's why the combination of psychosocial support that we are going to look in our next model is very critical, that we come to understand that some of the patients' psychosocial and spiritual support play a major role in palliative care. And I think to inform the patient and the caregiver about anxiety disorders in general, and including treatment options. Okay, so we enable them to see that they are not bewitched of what they are having, what they are experiencing. They are going through normal reaction, and this is how best we can support them to cope or manage that. So it allays the anxiety that way, because now they understand, oh, I'm not abnormal, I'm experiencing ABC. So that one is very important. So that one is under psycho-educating our patient. Actually, one of the pillars of palliative care is communication. And under communication, it's education, reassurance, and then family involvement and patient involvement. Okay, another one is psychotherapy. So in psychotherapy, we are saying we provide counseling for the first 2 to 8 weeks of the diagnosis of the anxiety or the discovery that our patient is going through anxiety. So we provided counseling, arrange those counseling sessions for the patient, so we can see how they are coping. It can be the patient or the caregiver or the family. So we have group or individual counseling sessions. It will be based on the need in front of you. And then what we are going to do there, we also explore the patient's thoughts and understanding of his or her presenting conditions. Because sometimes he is so anxious because he doesn't understand what is wrong with him or him. Some, they will feel like it's because they are bewitched. Some, they will think it's the end of their race and they will die very soon. So you will find them so anxious of separation anxiety. So there are many things. So if then they understand their condition, you'll find that they'll come to terms with it and then begin to live positively with it and understand that while they are still around, they still matter, Let the patient or family member talk about their fears and concerns. Actually, if you look around these management interventions I'm providing today, you can agree with me that it then means palliative care is beyond the drugs, actually. It's beyond the prescription and dispensing we normally focus on in most cases. It's about the mutual relationship between the giver and the receiver, or between the client and the provider of care. So the moment you create these relationships, the patient is about trust and understanding. Then once they begin to trust you, once they begin to trust themselves, because these chronic and life-threatening conditions tend to affect the psychological and social aspect of this patient, even the cultural and social and spiritual part of these people. So but explaining to them what they are going through and help them understand, they are empowered. They even come to gain the self-esteem and even be productive to help other people. So it's more of psychosocial care, supportive care. Actually, the best model of palliative care is saying that is symptom management combined with support, psychosocial support. These two, they support one another. That's why it is very important that when you are in a hospital setting and your setup doesn't allow you to have more of time, the hours we normally spend with them at home, then your strength is on the symptom management, the prescription, the emergency management, but then linking your patient with a home-based unit creates a very atmosphere for such situations whereby there will be these discussions. Let the patient and or the family member to talk about their fears and concerns. You know, the one-on-one sessions, the family meetings, having time to sit down, every man must speak his or her anxieties out. You know, I like God. One of the things I like to refer to, it's God as a Christian. God created a platform to deal away with fear from us. And he said, I will call this platform prayer. So I will allow you to come and verbalize your anxieties, your pain, your psychological, social neglect, and everything to me as God. And then you will feel at ease. So this is the platform we need to help our patient help. Help them talk. Okay. Help them talk about their physical, discuss themselves, their body, what is happening on their body, socially, how is their welfare, how is their life. You know, when we talk of social life, we talk about the sexuality issues, we talk about the financial issues, we talk about the family setup, the emotional care, psychological part. What is it that makes me happy? What makes me good? The practical things, you know, having food, seeing my children growing, able to take care of myself, watching television, watching sports, you know, help them talk. Each of these home-based visits we do as hospice, we are having time with the patient. Just talk. Sometimes we have a visit just to sit down and listen, talk about the farming, talk about life events, you know, talking with practical things with our patients so that you allay the anxieties, you know, real-time breaking news, what is making for the patients, spiritual issues, politics, what is happening, we have them, spiritual issues, finding meaning when our bodies are losing shape. No, this is psychologically helping our patient. You know, finding another source of strength when the physical and social and psychological areas are affected. You know, dealing with the issue of anxiety, having a strong and a healthy spirituality is very key. So we are helping them because also us as clinicians, we also benefit having a healthy spirituality. This will be dealt very much in our next module. Don't miss it. We also talk about loss issues, you know, the things we've lost. From diagnosis up to now, what losses we have gone through and how are we coping with those losses and anticipated losses. We call them anticipatory grief. You know, we are looking about the anticipation, what is going to come, and we prepare, you know, prepare for the worst and hope for the best. That's what we are doing. We talk about family. We're not talking about the family, marriages, family projects. You know, we're talking about family successes, challenges, allow them talk. Care of the left behind. You know, when I'm gone, this is what we go. I had another patient I will not mention the place because I met this patient these days, and then we were discussing, and I mentioned, you know, sometimes it's good to prepare for the end. Then we have to discuss advanced care directives, and then he opted to have an advanced care statement wishes that he wished to share with her daughter about her end of life. And now he's still far away to enter those moments. And then he said to the daughter, you know, my girl, for the first time, I want you to know that when I die, I want to be buried at home, not here. You know, for the first time, the lady has to understand. And then he mentioned his properties and said, no, there are things they have told my brother, this and this will be left with you. You know, the longest wishes, this is what I want to wish. While I was still working and serving at Shiselu, and I had another client who prepared for her funeral. You know, he take the money, distributed it very well, and you know, another client that I had, may he rest in peace also. He even tell the family that tell my because he was not here. tell her you will not find me again. Now I'm going. And then she died. And that lady blessed me when I was going for a marriage. And he said, I will have all the cows I was looking for. And I sometimes wish. So sometimes our blessings and care workers are hidden when we have the conversations with our patients. You know, they are very happy when they have people to talk with them. Ask open-ended questions. I've mentioned that one. Be non-judgmental. And when we are doing these discussions, for those who are approaching the end, at some point we'll look at end-of-life care and death and dying. We will have this topic or this element that is called, the topic called end-of-life care visions and dreams. They begin to have this, we have to balance between end-of-life care, end-of-life visions and dreams against confusions, and hallucinations. You know, there's a thin line in between. In beginning, your client will begin to talk about their old loved ones. So those things, we cannot be judgmental when they are talking about those things, but some of those things are healing to them and they allay their anxieties. So that's why it's very important when you are discussing these issues with our patients, we become non-judgmental. Okay, tell the patient and family that it is common to feel anxious. You know, make them not feel like they're feeling something strange. Allay them that, you know what, it is normal to feel the way you are feeling. And then sometimes we are saying that sometimes when it's panic disorders, especially panic disorders, they are most common on Breaking Bad News when we are discussing end of life, and sometimes they show up. I've seen they show up sometimes. People feel panicky. They panic sometimes when they're discussing advanced care directives, when they're talking about the wills and stuff. You know, they begin to be having something, but most of the time it's the panic disorders. I hope we have not experienced a situation, you know, practice whereby you will break bad news and the patient will just collapse because there's just panic. But the heart stops, make a little bit. So we introduced the relaxation techniques. When your patient is breathing so hard, maybe you're breaking certain bad news. So you bring the breathing relaxation technique. Breathe in slowly by your nose and hold for 10 seconds, then release by your mouth, you know, repeating 5 or 10 times. And then you find that your patient is able to cope with that anxiety. So we also put that one. And then we also strengthen psychosocial support and family involvement. When we are saying strengthen psychosocial support and involvement to allay anxieties and stuff, we are saying that it is not enough for, as a team or as an individual clinician at the OPD, in the ward, or at a home or in a clinic, to see your patient that is in front of you alone. The other thing is to work on your community skills and then put your community health into practice, whereby now you are remobilizing the resources around the patient. What we are saying here, when we are looking the patient in the team model, we see the patient at the center of every activity around. What then it means to strengthen the psychosocial support is that the strength of the patient is only reflected when you look at how strong is the psychosocial team around. So the immediate support, which might be the caregiver, and then the following line of defense, if I will be using Petit Newman's theory, you know, you look at the line of defenses. I would say the first defense is the patient himself and his psychological strength and spirituality, and then we keep it go to the caregiver around the family, and then we keep work around to the health system, which is me and you team, and then we keep go around when you go to the community around the church, the support groups, you know, the community at large. So look at around those psychosocial systems, so you can diagnose them and see if the patient can have somewhere to lean on and how much supportive they are. The friends, the people you know, if he has been a worker, the colleagues at work, because workplace becomes a second or first home sometimes to us who are working. So we need them to come back when the patient is sick. So they visit the patient. So the psychosocial comes stronger for this patient, then the anxieties will go down because the issue of separation will be there. I'm alone, I'm gonna die, you know. Yes, even the involvement of the family. When we're talking family involvement, we will deal with it very much when we deal with children. We involve everyone in the family, the immediate and extended families, but based on the patient priorities, because a patient will say, I don't want someone to be involved. But then the patients may find that children and the immediate relatives, the patient will be able to open up for them. Let's involve them in the care. This one is another therapeutic part of it, as after bereavement, when the patient is gone, so that they don't feel guilty of anything. But we'll talk about it when we deal about end of life and bereavement. Okay, and dying. We'll look around it. Why is it important that the family members come and support the patient it is? Another thing is that whenever, as a palliative care team, we discover that, you know what, we have tried all the above activities I've mentioned, but there's no improvement for my client. Let me engage a clinical psychologist for an in-depth or stronger psychotherapy, and then they are available with us wherever possible they are. You can have private psychotherapy wherever they are willing. We can have voluntary psychotherapists, or we have our national psychiatric hospital where you can have them. Then they will be able to help your client cope, or your family to cope. Sometimes our patients are bedridden. It's better to do some consultation and ask, then the clinical psychologist will help you. For those who are free, they can even go with you to meet the client and the family for a good psychotherapy or an in-depth professional psychotherapy. Otherwise, we cannot eliminate and say, I'm waiting for the psychologist to do something. Looking at above, there's a lot we can do in the absence of a psychologist. But in the palliative care team, we need a clinical psychologist, because one of the principles of palliative care says it involves the whole team whenever necessary. Okay. And then another intervention that we look at is supportive therapy. We give time to the patient. We don't rush them, because we know they are going through a lot, and then we take time with them, and then we go step by step with them, and then we do not minimize or belittle the patient or their concerns. I've mentioned that one. And then we do some visit the patient often. I mentioned one of the critical things here. I said there is a hospital-based model of palliative care and a home-based model of palliative care. Some of the patients cannot afford to come to my hospital frequently, but then linking them with a home-based unit helps. But then in technology, palliative care associations globally, and even including WHO, post-COVID, we have learned and embarked on saying researchers have found that also practicing or embracing technology in visiting clients comes effective and efficient. It means cost-wise and time-consuming, time-saving, and achieving more effect on the client. So we embark on telephone. Sometimes if you have patients who have embraced technology, we can have conference calls. You can have Zoom, like we are having Zoom today. So visiting frequently, scheduling those visits. But then again, it's based on, it's according to the patient's need and the patient's affordabilities when it comes to technology. So the needs of the patient will also influence your frequency of visit, and then you'll do that. But for those who can afford even to come to your hospital, you can schedule those frequent visits so you can support them through. Sometimes you will have those groups. It helps you to have them, and then you are able to do that. And then provide realistic reassurance. Don't lie to patients. Okay. Don't lie to the patients, give them realistic assurance. And when bad news need to be broken, broke them. And remember, realistic assurance does not mean be brutal to the patient, but be good, embrace or use good communication skills to help your patient understand what is happening and reassure them. Remember, when they see you, they see someone who has a solution to their problem. So realistic reassurance. I cannot say, I will see you every day, yet I stay in Lavumisa and you stay in Babane and resources are not permitting. Let you have reassurance that is realistic, not lie to the patient. Remember, if you are going to break the trust, a relationship between you and your client will never trust you again. And whatever you are going to say, they will never believe you. And sometimes one of the things I've discovered that once they have anxieties, one of the supportive therapy we need to do is to improve cleanliness and dignity. My hospice team can agree with me that maybe for the hospital one, they have not seen this. When they go to hospital, they come clean into you. But at home, you will find them sleeping and staying in dirty rooms. So sometimes you're having those people who ensuring that you improve their cleanliness environment, keeping them clean, have their clothes washed, So remember, establishing the team around helps you to get people who will help you with cleaning, will help you people who will sit down with the patient, talk, dignity-wise, self-esteem building. There's a client I've visited not very far from now, from another area in the world, because most of the time I'm going there these days. And this is what happened with this patient. This patient has seen water, has bathed or changed his clothes since last time was in June 2023. So I visited the patient in March 2024. He has not bathed since June. And he doesn't want to do that. And he's a man, he has a lot of anxieties. One of the things, because he's sick, he has urinary incontinence. You can think of the clothes, how they are smelly. I found out the clothes is like a long time ago, we used to put starch on our Zion clothes, and they looked tucked. So that's how the trousers were looking like. And for the first time since June, I was able to sit down with the patient, allay the anxieties, make an agreement with him, and then we go to bath. For the first time, the family, they are happy now. He went to bathing. Unfortunately, I've been back to gate because I've been told that he's back again to the old ways. So we need to put him through some certain therapies because he's sick indeed. But we need to help them dignity. I've been told, I did a television, I was told after bathing, he was walking around the home. He's weak, but he was walking and looking at himself for the first time. So we need to do that also. We are allaying anxieties because now you are repulsive to neighbors, repulsive to anyone because he was dirty. So we need to do that. Then also what we need to do to supportive therapy, we need to develop the goals of care with the patient and the family, enable them to partake, even if they have a little bit of dementia, try by all means to engage them where possible they can, so that they partake and feel still they are human. And the family, we don't know everything, but the family sometimes they will teach us how to take care of them, even the family, how to take care of them. Involve and use the palliative care ID team whenever necessary. The supportive team we have, like we are having it today here, we are here to support one another. Let's not die alone wherever we are. Another one that we used to do intervention that we can embark on, not least, but last, is the pharmacotherapy intervention. So in pharmacotherapy, we need to understand that for good response, sometimes we need to combine pharmacotherapy and psychotherapy, or the other therapies I've mentioned in the past slides. So there are medications that we use in pharmacotherapy to alleviate pain. We have pain medication. And when we're using pain medication, we follow the WHO pain ladder. And then one of the drugs that we have there, sometimes that works very well even when patients are approaching the end, it's morphine. All right? It helps us when they have severe pain and helps with morphine. It also has this calming effect to the patient. And also we have SSRIs, and we need to use these ones as a first choice when the patient have anxiety that requires us to prescribe these SSRIs. And then we have fluoxetine. Initial dose is 10 milligram and maximum is 60 to 80 per day. But you can visit the mental health desk guide to check this. Or the palliative care guidelines. So we have fluoxetine there. The other one that they call it's a centraline, if not mistaken. Yes, it is. Centraline initial dose is 25 milligram, maximum dose 200 per day. You can choose one of these. There's another one, citalopram, initial dose 10 milligram, maximum dose 200 milligram per day. So any of these three you can use as your first line choice to use. If you look at very close here, there's no amitriptyline here. So amitriptyline, not for anxiety. Then you have also the SNRIs, and there's what we call duloxetine as a second line. If we don't have, or you of course go for this one. Anxiolytics, I mentioned it before, when there's insomnia, we put lorazepam, is it 0.5 mg that we have? And then let me mention that insomnia, you may be tempted to use diazepam, but the tolerance is too high. So we don't recommend it there. Promethazine, not good because it makes the patient feel fatigue. But then the one with anxiolytic effect and relieving and help the patient sleep and feel at ease is lorazepam. So that's the one that we will recommend for anxiety with the insomnia. So we put that one there. As I've mentioned, tetracyclic antidepressant, for the most common available everywhere in the country, amitriptyline, are not good, but because they did not or they does not have anxiolytic effects like the SSR, the first line ones, the first choice. So they are not recommended. So don't put amitriptyline for anxiety. Okay, better get lorazepam or fluoxetine. And remember, when you are doing fluoxetine, sometimes you need to get the baseline weight of the patient and the blood sugar and stuff so that you can manage, because fluoxetine is also used for appetite boosting. So it gains, the patient gains weight. You will see those patients who are using fluoxetine, they are gaining more of weight. So you need to understand the side effects of these drugs. Okay. And then another effect, the last one, I hope, is the complementary and alternative therapies. One of the complementary that we have for our patient is traditional healers. Okay. Allow them to go there, get to their traditional healers, get their prophets, prophesy to them for the future, get them, help them with anxieties, faith and spiritual therapies, the pastors, I've mentioned this one, prayers, Bible, depending on the Quran, the Buddhist, whatever, they help a lot in this case of anxiety. And another one, the herbalist, they have those herbal medications that sometimes helps allay anxiety. So, yeah, actually, a combination of the above or all the interventions in any order may help you manage anxieties. In the complementary alternatives, I haven't tried traditional healers, but I've seen people who have worked and have left, have good fruits or have benefited from traditional healers, some from herbalists, but I have experience in seeing faith and spiritual therapies working well for our patients, having strong spirituality and faith in God or ancestors, whatever the patient believes, having effects on dealing with anxiety. So any combination, spirituality, pharmacotherapy, psychotherapy, and psychoeducation and assessment. So you will end up so the stepwise, I will not deal this much of managing of anxieties. You can go to your guide. It will also be available on our platform, and even in our YouTube, you can see it. So there are steps you follow. There's a community level where we are dealing with mild symptoms. And then there's a general hospital or health center where we deal with moderate symptoms. When step one have failed, you take your patient to a general hospital or health center. And then when Tina is hospice, we are at this level at hospice because we deal with them at community-based palliative care with home-based level. And then when we are not successful, we then move them to health centers and hospital through referral and linkages. And then from here, the responsibility of the team of palliative care that is here takes them to the national. Sometimes we find that the symptoms are real bad, and then we link them with the psychiatric hospital. So far, the National Psychiatric Hospital has never let us down as hospice. When we have linked the patient to them, they come back with good feedback, saying, you know what, thank you so much to link us with the psychiatric hospital. We have indeed get help. So let's do that for them. It helps them a lot. Thank you so much. For my conclusion, I would say the common forms of anxiety disorders in our settings are the GA and panic disorders, and they are both managed similarly as I've shared. Anxiety disorders are treatable conditions. So this is one of the symptoms that we can reverse. So remember, when we started this module, we said reverse the reversible symptoms. So anxiety or disorders are treatable conditions, so we can work together as a palliative care IDT team, deal with them. The mainstay intervention of anxiety disorders is psychotherapy and pharmacotherapy. So these two are more key when you bring psychotherapy and pharmacotherapy. That's why I take a long time to explain this one, because combining them yield positive response very quickly, but not eliminating the spiritual or the alternatives and the psychoeducation and others I've mentioned here. Always provide strategies to strengthen psychosocial support and encourage patients to adhere to treatment interventions. This one is very key. Psychosocial support is very important. Provide strategies to this. You know, you learn on the ground, and then you're working with the families, you come up with the strategies, and then again, remember to encourage them. Once you prescribe those therapies or interventions and pharmacotherapies, help them adhere to the treatment so that we can all achieve the goal. Actually, definition of the goals of care must be well understood between the two parties, which is the patient and the family, and you as a clinician. You will read very well. Thank you so much, colleagues. That's what all we have to share today on anxiety management in palliative care, or what you call palliative care psychiatry. We have just extracted anxiety then. In our next module, we will then talk about depression in palliative care psychiatry or in palliative care. So I don't know, colleagues, if you can want to share and discuss other points from this one. I have a few minutes today to allow us to discuss this one. And then next week, next session on the 3rd, we'll have our case and depression, and then, yeah. Anyone who wants to add something, colleagues, or share something? I can tell that some people have dropped along the way because of the network. Yeah. I can see numbers have gone a little bit down. Yeah. I don't know if you want to say something, but the video will be available on YouTube for any colleagues who have not made it today or who have just dropped along the way due to poor networks and other reasons. Otherwise, our next session will be on the 3rd of April, and we'll be looking at depression. Yes, we'll be looking at depression. Anyone wants to say something before maybe we can? It was just sharing and examples and experiences, presentation. So, yeah. Anyone? Today the network wasn't good.
Afternoon, Tim.
Yes, Mama.
Yes, thank you, Mahlangu, for the very enlightening presentation, encouraging and emotional as well.
Yeah.
Mine is just to say, for real, Tim, when we talk about palliative care, our presence means a lot to the patient. The approach, as you are always doing, passionately, compassionately, the listening is almost everything. Sometimes the patient would say, the mere fact that someone has listened to me has lessened the burden. So therapy is more than medication when it comes to palliative care. Thank you so much for this presentation, for the work you do, and for the insight in the program on palliative care. Ngiyabonga.
Thank you, Mama Siyabonga. I don't know, team, anyone wants to add something for those events so that even our colleagues who have dropped out will catch up with us on YouTube and be able to get what we discussed today. And those who didn't make it, I know to next session we'll have a lot of our colleagues who will be back. Some are even outside the country, busy with other activities, yeah? I don't know if anyone want to add, otherwise Marga has also said that. And we are hoping in Eswatini, we will do better each day in balancing the needs of our patients beyond any prescription and curative therapies, looking around beyond the curative therapy and see what we can help our patients do. All right. I don't see anyone wanting to say anything, colleagues. Thank you so much. And thank you so much even for those who managed to join us and leave. I saw Malaika joined us today, but I hope due to poor networking, we dropped off. I saw Zamoto Day was here. I saw another Lukele joined us, but because of network got. I saw a lot of other colleagues joining. Others even informed me on WhatsApp that they are trying, but they failed. I started maybe to encourage our colleagues who will even have opportunity to see this video to say, let's try to join around 1:30 and so where the session is already open. So on the 3rd of April, we will have our session on depression. And we would like to inform all of you colleagues that whenever you have joined, you accrue for yourself 1.5 points for our CBD. And then if you have attended almost 70% of the session, at the end of this module, you will also have opportunity also to write our post-test, which will enable us to share a certificate of attendance for you as a proof of your attendance, which also stipulates your CBT points for this module. And also we are saying let's encourage others to join. In palliative care, we can do better whenever the situation looks bad, but there is something we can do to support our patient. Thank you. May we meet on the 3rd of April when we'll be looking around on depression. Bye-bye, colleagues.